It's not every day that you get to see Dr. Rohatgi. Getting an appointment is almost impossible, but so glad to have him and Divya over. So Divya was sharing a rather alarming statistic with me earlier in the morning, and she said, 1.3 million new cases of cancer are detected every year in this country. And that's an alarming number. But what is more alarming is 70% of that number is in the advanced stage of cancer. And I think this entire conversation is all about the continuum of cancer care that the diagnostics from Guardant provide, and that how, as Dr. Rohatgi put it beautifully, cancer can be a matter of hope or a matter of cynicism. And as Divya said, she'd much rather believe in the cynicism than in the... Yeah, but cynicism has great hope in it as well. So to start it off really, all of us have someone we know who has been affected by cancer. My mother had it for 14 years. I must concede that I stayed away from it because I just didn't have the courage to understand it. My wife and my brother navigated it beautifully, and then my sister-in-law did it towards the last few stages. But why do you think, are we seeing the rise of cancer? And why is this incidence increasing by the day?
So first let's talk about that 1.3 million. This is clearly the patients who are recorded. And you know our record keeping in India is brilliant. So that number, to anybody's imagination, may be a lot more than that. The worldwide cancer incidence, when you put it together, and you think about the biological plausibility of that.
Sorry, I don't know if it tells you anything more
Okay.
to do, but could you just... Yeah.
Is this better?
Sir, we need to up the air conditioning also. We need to up the air conditioning.
Okay, so when we think about the rising incidence of cancer, the rise is almost biologically not plausible. It's impossible. So let's put it together. First and foremost is certainly an increase in diagnosis because of better techniques. The technology has improved. The physicians are now aware. I'm not going back very far. 15, 20 years ago when I was in training, I look back and I can't really forgive myself for calling a lot of cancer tuberculosis. And I look back and say, that must have been cancer. I remember labeling people as sepsis, not realizing that the cause of that actually might have been cancer somewhere. So we are certainly better at diagnosing today. And that's a very big chunk of the fact that awareness amongst physicians and people have gone up. But that's clearly not the only reason, right? We are seeing a lot of young age cancer in India, as I was talking to them before. So the increase in incidence, if you look at the World Cancer WHO, it talks about the 5 big ones. It talks about alcohol, smoking, obesity, exercising, and clearly now talking about processed red meat more than 70 grams a day. Now when you look around, it's very interesting how obesity is an actually acceptable norm in the society. If people start losing weight, they say, "Kamjor ho raha hai, kya ho raha hai, khai piye ghar ka nahi hai." There's a problem there. And when that happens, then the whole society is obese. We saw that happening in 25 years ago in US, where obesity was a norm and the cancer incidences were high. I think Indian society is by far the best society not to exercise. We just generally think that going to the kitchen and back, and if I pick up my remote and switch on the television, I have, Doctor Sahab, मैं तो चलता हूँ, हर रोज चल रहा हूँ मैं तो इसमें I'm a very fit person. We don't exercise as a society. That doesn't count my brother-in-law Sameer, because he's after us all the time to exercise, but generally we're not an exercising society. So 2 big factors: obesity, exercising out. Then fruits and vegetables. We're a carb eating society. How much truly boiled fruits and vegetables do we eat? So no exercise, bad diet, pizza is entered, everything that has to go wrong, and comes in the new 2 big ones, alcohol and smoking. It's very amazing how when we were in school and just about medical college, smoking was on the rise and a lot of work happened actually, and smoking went down the cities and has exploded in the rest of the country. So yes, smoking has gone down in Delhi and Bombay amongst the teenagers, the young girls, not gone off, it's gone down, but it exploded in Far East, it's exploding in South, it's exploding in the West. And so you will see an increase in rise of cancer because alcohol, which is now rampant rise everywhere, smoking, obesity, lack of exercise, and processed red meat. We do talk about telephone towers, we talk about fertilizers, we talk about HCV infections, we talk about cirrhosis, we talk about cervical cancer, and these are all very important, but the 5 things in our hands, Swapan, we don't do. We don't control our diets, we don't exercise, we do not control alcohol, we really are not looking after smoking. And we are entering into processed red meat, we are entering into we are not vaccinating for cervical cancer, and yet we do sit and talk about telephone towers, fertilizers, and the whole belt and everything else.
No, but share that Northeast statistic of people starting smoking at the age of 10.
So at the age of 8, at the age of 8, age of 10. So this is amazing. So there was a very interesting epidemiologist who asked kids in class in Delhi, in Bombay, and in Mizoram about raise your hands that do you smoke? And he went down to class 8, children of class 8 and 10. And of course, nobody put their hands up. Then he asked them, can you tell me if your friends smoke? And everybody's hands were up, right? And it was amazing how he did that about 10 years apart. And the hands were better in Delhi and Bombay in class 10th. And they were almost entirely, everybody's hands are up in the Far East.
But doctor, my entire perspective is that companies like Juul, my entire perspective is that companies like Juul and vaping has destroyed an entire generation. Because I believe, I have 2 sons, one is 23 and 25. They were absolutely dedicated sportsmen, both of them. There was no question of them touching a cigarette. But they vaped for a while and then they gave it up. But I just think vaping has just destroyed this entire generation, or this generation possibly would not have smoked. I mean, that's my theory. But having said that, Divya, you live every moment of your life with enough and more data to tell us all, what do you think is the cause behind the rise of the incidence of cancer?
So I think Dr. Nitesh has covered most of it, right? I do think there are some environmental factors that play as well. We've covered a lot of the behavioral factors, but environmental factors like pollution, and especially if you take it in Delhi, and what impact that's going to have in terms of lung cancer incidence in younger people who are non-smokers is something that we'll find out. So I think just in addition to all the behavioral factors, maybe some very key environmental factors to point out.
Shall we jump into liquid biopsies versus tissue biopsies? And because, I think most people want to know more about it. I just deviate from the script bit.
Okay, so let's talk about what is liquid biopsy. It's a very interesting nomenclature, liquid and biopsy, because we've all thought about biopsy as you put a needle into the place which is looking wrong. If there's a lump in someone's liver, you put a needle, you take the tissue out. That's the definition of biopsy. And then you say liquid, you're like, what, are you sucking things out or what? But really, liquid biopsy is a blood test which looks for the cancer in the blood, right? We're going back now more than a decade ago when we started changing our nomenclature of cancer only from saying these cells look abnormal and can penetrate into the basement membrane and spread the definition of cancer to say I can differentiate between a DNA of cancer and non-cancer. I can differentiate your normal DNA from your abnormal DNA in these very cells, in the tissue. And then it was, in fact, the pioneering work of the team at Guardant, which were the first ones to do liquid biopsy, which said, by definition, this DNA has to travel to become cancer so we can catch it in the blood. And they started doing blood tests of patients with initially, obviously, stage 4 cancer. And they started measuring that. And it was very interesting how not only could you pick up cancer in the blood, but you could also see the response to treatment by that DNA going down. So it was almost proof of principle. And then you saw the cancer DNA go up and you saw it on the scan. And it affirmed that actually as a proof of principle you could do that. Along with that, technology changed at the same time. And we started picking up different DNA from different cancers. So the lung cancer had its own profile, a kind of conglomerate of if you have A plus B plus C plus D, it's lung cancer. If you have F plus G, you have HCC. If you have B plus L, then it's breast cancer. And at the same time, we started doing possibly the most spectacular change in oncology, which is going from chemosurgery radiation, especially in stage 4 cancer, to saying if I have a target, if I know my cancer is being driven by a particular abnormality called mutation, and if I can find the key to that, like a lock and key, then I can stop the growth. So on one point, we were looking at cancer DNA and saying this DNA looks different from normal cell. At the same time, we were actually looking for that in the blood, and at the same time, we were actually finding the abnormality, which if can be blocked, can actually treat cancer. And so the research put by, I almost say the right time, everything happened together. This was the actually starting of the Moonshot program, where they said, do everything together, don't break it up, which is what we used to do before, and see what works together. And came in lung cancer, where a blood test found that yes, you were having cancer. Of course, we needed biopsy to confirm in the beginning. Now we are changing the way we think about it, still not approved. Not only did it say confirmed cancer, but how bad was the cancer? And it started finding the abnormality. The first one was the EGFR, where if you found it, you gave them people a pill a day, and I included, saw cancers melting away on scans, on symptoms. You could feel the lymph nodes going away. So this was partly solid, partly liquid, but then, of course, you can imagine how easy it became. And the whole biopsy phenomena changed to, can we do liquid biopsies? And came in the whole concept of a blood test to say, yes, you have an abnormality. That abnormality can be targeted by a non-chemotherapy option. You can deliver that, and very interestingly, as we saw the future of it, when you give it, it went down, the DNA of the cancer went down, and when it failed, it in fact went up. And in fact, now we are saying that not only can we see it going up, but we can find the next abnormality that develops as the cancer evolves. So it, to my mind, became the strongest diagnostic tool in most cancers, in lung cancer, in melanoma, in colon cancer, in breast cancer. We are finding lots of interesting things, when others we'll find soon. So it became most interesting tool. It was easier. It was very quick. We were not losing tissues. We were not doing again and again procedures. And so came the world, the liquid biopsy.
My next question can actually be answered by both of you. You as a practitioner and you, Divya, as representative of a company that is deeply involved in the entire continuum. So what really are the trends that we're seeing in terms of, in terms of patients with advanced stage disease and early stage disease? I know for a fact that, Guardant is involved with Guardant Shield, which will be detection, and, Guardant has the entire continuum of detection, attention, and stagnation, and arrest of the disease. So really your comment, and then Doctor, your comment in terms of the broader trends that you see in, early stage and late stage cancer.
Yeah, I mean, even if you just put Guardant aside for a minute, because I don't want this to be a conversation about Guardant, I want this to be a conversation about cancer and diagnostics. If you put a mission in mind, which is simple, and then you attach it with a bold vision, and you say, hey, we want to help conquer cancer, and how can we do that? What is the tool that's missing? And if you think about the fact that in a lot of other diseases, we're very comfortable going and getting a blood test. We get a blood test for almost all of our disease checkups, and we feel like we can rely on that blood test. So there are two things we're trying to solve here, which is one, can we do it as easily with blood, even if the technology is difficult? And two, can we create enough confidence that physicians around the world feel that they can adopt the test to make treatment decisions? And I think with that philosophy, lots of diagnostic companies are working towards figuring out, okay, what do we do with advanced stage cancer? I mean, Swapan mentioned the number. We have 900,000 advanced stage cancer patients being detected every year. And many of these patients will progress into the next year and the next year. And as we know, cancer is smart. Once you give it one therapy, it will want to find a way to evade that therapy, to change itself. And then what do you do? How do you find that next therapy? So in the advanced stage cancer, the rule of thumb for high quality diagnostics and the great part about blood tests is to see how do you match a patient to the right therapy as quickly as possible and find that one abnormality that is actually driving the cancer. And not just the first time, but every time the cancer tries to evade the treatment, every time the cancer thinks it's become smart enough to somehow move and progress. Every time, how do you attack that? That's one side of the equation. The other side of the equation then is stage 1 through 3 of cancer. This is where people are getting surgery, typically. And the questions that are asked are, was there any cancer left behind? Did we really get it all? And how likely am I to recur? And do I really need to get chemotherapy or radiation or some other kind of therapy, or can I just avoid it? I've just had surgery. Now, this is a field that's rapidly evolving, and this is a field that requires diagnostics with a precision that goes beyond, even advanced cancer. Because think about it, when there's a lot of cancer in the body, the cancer is shedding a lot of DNA. But when there is small amounts of cancer in the body, there is a small amount of DNA, and so the test needs to be really, really sensitive in order to capture it. And the field of science needs to evolve to see, okay, now that we capture it, what do we do about it? How can we trust the results? Are they clinically applicable? And this is where a lot of work is going on in the field of stage 1 to 3 cancer. And then move towards screening. This is essentially the North Star that everyone wants to work towards. This is where we start really bending the curves of cancer and hopefully flipping the equation where, one day we'll sit in this talk and say we're finding 70% of the patients at stage 1 and 2, and we're finding 30% of the patients at stage 3 and 4. And that's the hope that cutting-edge diagnostics bring to the table. And I'll let Dr. Nitesh answer the
I think
therapy
I'll add
spectrum.
a very important aspect to it. That so as simple as this sounded, take a blood test, find cancer, there is a huge amount of difficulty in validating it and getting the quality right. If you can just imagine how important this is becoming, that you, in an advanced stage cancer at least, pick up the right problem, give the right solution, and of course there's a huge opportunity cost, because if you get it wrong, then time is wasted and sometimes you can't get back. So to get it right can only be possible if you have enough validation and approvals, actually, the FDA approvals and stuff, to say that you actually got it right. Because a false positive is a big problem. And a false negative is an even bigger problem because you've given the patients wrong treatment. So while I was trying to address Swapan's question of advanced stage, middle stage, and early stage, I think Divya brought up the question of quality, and I think it's very important to address that quality question. We in India are sitting on a 70-30 ratio, and that's where actually accessibility and affordability comes in, because one of the reasons we're sitting on 70-30 is because we do not have accessibility and affordability, so people don't go for testing, and they're sometimes afraid to get tested because they know they can't afford that. But the only way to switch that is, of course, you give affordability, you give treatment, but also you give availability of a test which can detect early. Now, once you start doing that and you detect it early and then you do go through surgery, there will be a question, because the central dogma of treatment today is to give chemotherapy to almost everybody after surgery to reduce or finish the small microscopic cells that remain behind. We have a lot of statistical models. We have other treatments, for example, breast cancer, where you can predict whether somebody is at a high risk or a low risk, but the central dogma remains. When Guardant, and this is only in colon cancer yet, and it's going to happen in another cancer soon, came back with a test, as did another test in USA, that for patients with a limited stage colon cancer, that was the first and the best cancer to test on, because there was a cusp in all our minds as medical oncologists, should I not give chemo? As compared to somebody we always thought give chemo or don't give chemo. This was always a cusp. Stage 2 was always should I not? And then Guardant came along with a blood test, and people who did not have DNA in their blood at that point were randomized to give chemo and not give chemo. And it was very interesting that at the end of the trial period, when you gave or did not give chemo in this group, it did not impact survival. That was a great proof of principle, that yes, you can do that. Now, of course, what will be the next step? You'll run it through stage 3s, you'll run it through stage 1, you'll run it at breast cancer, at lung cancer, finally at pancreatic cancer, and so on and on and on. But as a technology, it was a great advancement where you're cutting down toxicity. And in fact, even in a socialistic world, you're saving that cost to diagnose more patients in early stage. Imagine the importance and the beauty of that in a country like India.
And maybe there was a conversation you and I were having earlier about even advanced cancer patients, right? We talk about cost and affordability, but the cost of doing a biopsy, the cost of admission, the cost of it going wrong and adverse events, and serial testing and wrong therapy till you find the right one.
So there is no doubt the cost of therapy is always more than the cost of a test. There's almost no doubt on that. So especially with very expensive therapies, we talk about targeted therapies and immunotherapies as almost a center stage of therapy in the future, because they're non-chemotherapy options, they're less toxic, they can be given for decades or weeks together, months together, years together. Now when you think about that, each of them is a couple of lakh rupees. So when you add a wrong therapy for 6 months for, let's say, average of 2 lakh rupees, is still much less than the cost of the test, and certainly much less the cost of making somebody unwell with the wrong therapy. And I was quoting an example actually of a patient where he did the test, he did lung cancer, he did the molecular testing, we tried to find the right abnormality, we didn't find, we put him on chemo, didn't work, we put him on immunotherapy, didn't work, came back, said, what else can I, came for a second opinion. I said, let's test again on a different platform. And the minute I tested and I found a very simple, again, that EGFR mutation, and I gave a tablet, he was fine 15 days later. At 3 months, the scan was good. And the first thing he came back and said, was I on the wrong treatment for 6 months? And he said, not only the cost, not only the unwellness, but the fact I didn't go to work, I could have earned all that money in the time that...
I know someone who's spent whose father spent 50 lakhs on immunotherapy and continues to be impacted by cancer. So here's my point, and that's my basic point. I'm once again deviating a bit. I think why all three of us are terribly grateful to all of you, actually we are, is that this can only work if there is empowerment, if there is knowledge, if all of us go back from this evening and tell people that, this is possible, we can do this can happen to all of us. I think cancer is such a black hole of knowledge and information. I mean, a guy like me didn't have the courage to ever ask my mother's doctor in the initial stages as to, what's going on or what is really happening. I had no idea about what she was going through. I just turned away because I had no knowledge. But I think the interesting thing is that aside from accessibility and affordability, if communication and knowledge dissemination, which I think was done rather well with something as trivial and small as COVID, okay, if we can do this with liquid biopsies, I think we would have done a great service to this entire country, if not the world.
Even beyond liquid biopsies. I think we generally as doctors, I'm not saying oncologists.
Yes, even doctors.
Generally as doctors, we are very poor at communication.
Because, now my entire point is, why didn't I ask a doctor about liquid biopsy? Because I didn't know about it myself. So, and why didn't he tell me? Because probably he didn't find it necessary to tell me. So it's a two-way corridor of no conversation because no one wants to talk to each other. But tomorrow, if Khuda na khasta, someone I know has cancer, I can go up to Dr. Rohatgi and say, why can't we do a liquid biopsy? So I think there is this whole communication, and communication is all about empowerment, vacuum that I think we all must fill. On to the next one.
Can I just
Sorry, of
add
course,
something to
of course.
that? I also feel like there is a huge burden we're placing on doctors, and I really feel bad for our oncologists because they were not trained to be molecular detectives. They certainly did not get the training to be genomic experts and molecular detectives. And I feel like all of our doctors these days are playing Dr. House, if any one of you has seen that show. And that's kind of what we're expecting off of them. So I think we also have to give some credit to the fact and benefit to the fact that the community is trying really hard to set consensus papers and guidelines, and many of us are doing cross-industry collaborations to set standards on diagnostics, to set consensus across various countries, because what works in India may not work in Korea, may not work in Taiwan. So how do we make sure that some of these consensus apply to that population and work with leading oncologists together to then say, okay, how do we disseminate this information further? And do sessions like this, which, thank you for coming, and hopefully we'll have more of these.
I think that's very important, and that's also adds the point that irrespective of how good this testing is, it's not for everybody. So it is important to know when not to test also.
Exactly.
That's a very interesting point, and I didn't know about it, so tell us about it.
So on one side we are saying that it's easy to do, it's picked up, and on the other side we are saying there are guidelines and there are guidances and there are flow charts. Why is that the case? Because this is scientific, this is data driven. You have to first prove that when you do, for example, ovarian cancer, right? It doesn't shed as much as ovarian cancer as it sheds in lung cancer or melanoma or breast cancer. So the threshold of ovarian cancer will be different. So first you have to prove that when 1,000 patients with ovarian cancer were tested, it generally benefited in a certain way. Only then otherwise there'll be havoc, right? There'll be chaos. And chaos could be good, but in this case, the chaos may not be, because you will very easily find people testing and not knowing what to do about it, because the test was not meant for that setting. I spoke about stage 2 colon cancer, but we haven't yet validated data for stage 2 breast cancer, for example. So if somebody tests in breast cancer and does not find the DNA and says you don't need chemotherapy, and then after 1 year it comes back, actually it is the fault of the person who prescribed it.
I agree.
Okay, so we have to know our data, we have to know the studies, we have to, and they have to spend time. And not only they, I mean, every company that's in diagnostic sphere has to spend time, effort, and money in studying the group, publishing the group, understanding the data. And in fact, that's where they're very strong, because they have hundreds of publications as compared to many others. So it's very easy to feel confident that, I'm doing the right thing for the right patient, for the right indication at the right time.
And maybe also just to add to that, right? Technology tends to be at the forefront. And I'm sure many of you out here are entrepreneurs and you understand the concept of disruption. Technology tends to be the disruptor. And every time you disrupt something, you still need to give evidence, and you need to give time for adoption, and you need to give time for it to become a guideline. And when it becomes a guideline, that's when you actually see oncologists at a mass level very comfortable in adopting it. You always have people who are at the forefront of technology adoption, just like any technology, right? There are people like Dr. Rohatgi, there are people that we know, in India, where we see them shaping these practice-changing concepts with us. We see them working with us in generating data that's going to benefit. What does this mean for an Indian population? And challenging that and questioning it. And are we ready to use it yet? If not yet, when can we use it? And that dialogue back and forth between industry and doctors, I think is very healthy, because at the end of the day, that benefits the patient.
Yeah. You were wanting to say something.
No. I mean, but it's politically incorrect, so I won't say it. I might say it later.
That's very sweet. That's a first.
So how are therapies for cancer evolving? I mean, we do know that lots of therapies exist today, but how do I know what's going to really happen tomorrow? Let's address the fattest elephant in the room, which is AI, and how is that going to impact diagnostics, all of that.
So let me paint the whole picture. So let's go back to...
This is a Monet moment.
surgery and surgery alone, and surgery and surgery alone, to surgery and chemotherapy. Chemotherapy came in very early from mustard seeds, 5-fluorouracil. Surgery and mustard seeds. So surgery and chemotherapy. And then came in cobalt, and surgery and chemo and radiation. And for a long time, driven by the American great pharmaceutical industry, we were talking only surgery.
Now you're politically incorrect.
I'm more politically incorrect than you are, Swapan, at times.
Great.
So surgery and chemotherapy and radiation. And it became quite evident that we were over-treating patients. We were trained to say, to save 5 lives, it's okay to treat 100 patients. And actually, when you ask those patients and you ask them, most patients said, yes, it is okay to over-treat us to save 5 lives. Every life matters, right? But we clearly needed more technology to treat these patients better. And I think 3-4 more things happened. A, targeted therapy happened. As I said, lock and key. Harrison ka tala hai, yellow, flat key, 326 written on the lock. You'll take out 326 key and you'll put it and it works. Right? So that's very precise treatment for your DNA, your cancer, your mutation, your abnormality, and hence the name precision medicine. Almost simultaneously, we started learning that we've spent, I don't know how many billions of dollars and how many years wrong in trying to stimulate immunity to fight cancer. Well, the cancer was never about lowering immunity. It was about escaping immunity. It was about the cancer cell creating a camouflage or an umbrella or a barrier around it, which disallowed your immune cell or your T cell to find it. It was there, it had the gun, it knew it could shoot at sight, but it did not know who to shoot at. Came in immunotherapy. It simply went and took the barricade out. The immunotherapy, the immune cell was there, it started fighting the cancer cell. Did it work for everybody? No. On the whole, only 20%, because only 20% cancers were using this as its key mechanism. Okay, there are another 20 which are using a very complex immune mechanism. You'll see this ride more and more in the future. So from future perspective, immunotherapy will be huge. And then came in some other small but very effective therapies. We will see a rise in magnetic therapy, which is very interesting. You put magnets on the body, and these are strong magnets for 18 hours, 20 hours a day. We already got approval in brain tumors. And because every cell multiplies by dividing one cell into 2 using a magnetic pole, north and south, to divide the cell, if you just make it complex, you can actually stop letting it divide. And very recently, other than chemotherapy, radiation surgery, and then saying targeted and immunotherapy, and now magnetic therapy, came in selectively giving chemotherapy in cancer cells. So we are combining antibodies that go and recognize the fastest multiplying cells, i.e. cancer cells in the body, and injecting chemo only into them.
Oh, wow.
Okay? The big problem, we don't know who to give what.
What does that mean?
You need a better diagnostic test, even better than what we're doing right now.
Okay.
Because what you need to do is find out that 20, that 5, that 10, and that 20, and then finally there will be still some who none of this works, chemotherapy still works. You cannot afford to lose them because you don't have any of this. So you do need we need to be much better than this already. We do need better diagnostic ability and AI, so that the HI, human intelligence, uses the AI and the diagnostic technology to its best ability. The reason I am a cynic with AI alone is because AI is dependent on data, and somehow physicians were not trained to collect data very well. We do collect data in clinical trials, but your AI is not going to work with that. Your AI is going to work when physicians start collecting data in practice. And physicians don't know how to do that. As physicians, we were not taught the basic 3 mantras of good medicine. We were not taught about nutrition. We were not taught about psychology. We were not talking about physiotherapy and body. And we were certainly not taught how to talk to patient and how to write about it.
Which brings me to my next question. There is no element of psychotherapy or psychology that is employed to deal with the trauma that people diagnosed with cancer go through, the trauma that their families go through. Why is that? Shashank, that was a question that you were asking me. I mean, it's a serious issue because wo ghar mein cancer hai to usko lekar.
So I'll divide that into 2 parts. So part number 1, this is very interesting. When there is a new diagnosis, your mind is running at 200 miles an hour, no amount of psychotherapy really helps. Okay? Because you're really saying, between you and your ego, you know you can find a solution to this therapy. And so you're going hook, line, sinker between Google Baba and ChatGPT to find that solution. Okay? If somebody says, just sit down, let's talk about it, you say, I don't have time. And that's our first touch point where most psychotherapy is tried to be delivered. It's a misfit. Now, at a point where you are really realizing that you're in deep problem and you need psychotherapy, actually the system is not good enough to pick you up. And again, I'll say that. That's partly because the department of psychotherapy is dependent on the physician, is dependent on me saying this patient is in distress. And I was not trained in medicine to do that. In my medicine, I had a chapter in psychiatry. If somebody goes mad, I know what medicines to use. I did not have a chapter on if somebody looked distressed, can I actually help them in a certain way?
Fantastic. Fantastic.
But this is the big change. I mean, we as a group, we struggling, but eventually we really want to create these pillars of mind, body, nutrition, which are independent, and I'm quoting the word businesses, so that they are big by themselves at par with the Department of Surgery, Medicine, and Radiation Oncology. Now, when we empower them to be that big, then they will start picking up the patient. They will develop systems. When we empower these people, they will develop systems to pick these patients up. And patients will come and say, I am in touch with this person. Do you mind? And we'll of course say, no. I mean, we won't say this. That's a problem. But we're not thinking about it. We are thinking about the next drug to give.
Divya?
I was also just thinking that, there's an aspect of trauma that's also associated with just the amount of testing that a patient has to go through after cancer is confirmed. Yeah. I mean, there's one whole set of testing that first happens to confirm, okay, this person does have cancer. Everything. And then everything, it's like starting from basically ground zero again. And there is something to be said about shortening that diagnostic journey and really helping patients get on that treatment as quickly as we can to also reduce that trauma and the psychology, because we are seeing loads of evidence that these patients are performing better when they're put on that treatment at the right time. And I think there's a lot that we need to do in the future, and we all agree there's a lot that needs to happen in the future, whether it's tests, whether it's therapies, whether it's holistic care. But there are things we can do here and now, and I feel that sometimes we're using a lot of these other things as excuses to not do what's here and now, and we need to start acting on that almost immediately.
So then what's the theory between the right therapy at the right time?
Sorry?
Then what is the theory behind the right therapy at the right time?
Yeah, so I think actually, before I say anything, maybe I'll ask you to introduce yourself and say something. What is?
So okay, you carry on. I think we just need to give a context.
Hi, this side Andrika. My father is facing from an advanced stage of cancer, lung cancer. And it's been a year, I guess. Actually, Dr. Amit Agrawal is seeing him. He's my cousin brother as well, and he's a cancer specialist in Fortis. So, honestly speaking, 30 seconds and life changed. I remember I was partying with my friends, and my father just called me up and told me that he is suffering from a lung cancer. So, honestly, I'm being a youngest sister in my family, youngest daughter, and unmarried. It was very difficult for me to, deal with this situation. What next? Right doctor, right response, right guidance is very important for cancer, because within a second, if you take a wrong decision, you lose your near and dear ones. I think when I got to know about liquid biopsy, Guardant especially, Dr. Amit Agrawal told me that, okay, tissue biopsy and liquid biopsy is important to get it done, to know what stage it is being. You just know it's a lung cancer, you don't know the stage. You don't know since how long it has been, developing in my father's body. So to know the detail, I got it done liquid biopsy in March 2022, where I got an option of HER2 injection, but it was only and only available in Rajiv Gandhi, that too in a testing, process. They were not declaring, okay, we'll only and only put the, HER2 to my father's body. So I was like, no, this is wrong. You can't experiment with my body, like my father's body. So we started on the spot of chemotherapy, and honestly speaking, it worked for 6 months and 8 months. After that, it boosted up. Like the cancer was so aggressive, it responded only for 6 months and it didn't respond after that. My dad has, this January, he expanded his cancer to the hip, to the spinal cord. Again, my doctor asked me to get a liquid biopsy done to know why this happened, because he was doing pretty well before the, January. But we were shocked to see him, the cancer boost up. Chemotherapy didn't work out, radiotherapy didn't work out, immunotherapy didn't work out after 6-7 months. What next now? So the moment we got a liquid biopsy done, thankfully for the Guardant company, trust me, HER2 was the medicine after a year got identified. Again, you should try HER2. We were very scared to try HER2 just because in first co, Rajiv Gandhi says that the DNA is not matching. We can't, get infusion in HER2 in my father's body. But Dr. Joshi literally helped me out for the detail. Dr. Amit Agrawal really helped me out. Dr. Richa, she is an US doctor. She helped me out, and everybody said me to the positive note, just try. Why not just give it a shot when you're given a lot of chemotherapy, a lot of immunotherapy and radiotherapy and stuff. And then in January, we started doing immunotherapy experiment with my father, because the cancer is one disease, you just can't stick to one medicine. It keep on changing with the situation of PET-CT scans reports. And trust me, I'm happy to tell that 20% of my father's disease has improved with HER2. It has improved 20%, and it was all help of Guardant liquid biopsy. It shows me, okay, HER2 is the only medicine can help you out to, go further if you want a recovery. And I remember the day one, my doctor said 6 months to 1 year, no more, not more than that, he can survive. And this is 1.5 years he's surviving, he's improved 20% of that. And when it says trauma, I was listening about that. Honestly, my father has a very strong willpower. He has a willpower, that is why we kids have a willpower. But when you got to know about your family, your father, who's the only one who's looking forward to you, it is very trauma. Like, you can't sleep, you can't eat, you are just zombie, you just keep researching what next, what's going on. Because my dad is non-smoker, non-alcoholic, never had outside food, but he still got a lung cancer last stage. So it means that unhealthy life is just not drinking alcohol to cigarettes. It also is stress, environment, and the work you're doing. Because he was into iron casting factory, and which says in liquid biopsy, he has cancer since 14 years. And last back 8 years, he shut down all the factory, but still the cancer was there. And that was because of the manufacturing of steel. Thank you.
I think that's very touching. Just to describe what she said, this is very interesting because what her father has is a breast cancer protein in his lung cancer, right? This is HER2. Now you could argue why that is happening, but we forget that we all started from one cell. So when our cancer decides to go rogue and become cancerous, it can, as a mechanism to become cancer and escape, take up any growth factor, any receptor from any cell. Not take up, actually develop that, because it can go back to its basic embryonal stage, and as it goes back, it can pick up any protein that gives it evolutionary advantage and then grow back. So in her father's case, EGFR ERBB2, which is a HER2 positive protein, 30% breast cancer women have it, was found, and we would not be testing a breast cancer protein in a lung cancer, would we? Certainly not in a tissue biopsy, usually. We'd be looking for lung cancer proteins. And I have a very interesting breast cancer patient with a lung cancer mutation, ALK, which we just published recently. And the same thing happened. You gave that treatment, it was targeted. It was that example that I gave, lock and key. This lock was HER2. The key was NHER2, which actually came into NDTV day before yesterday. That has been approved by DGCI only day before yesterday. So they were importing it, I'm guessing. And the minute you applied that lock, a disease which was going up and had to keep going up, and would have been great if it stabilized, actually went down by 20%. And that's the power of right test.
Yeah.
Maybe at even a time before that, a right time, and a right treatment, which is available but can only be given if you find that problem.
Yeah.
But then,
Can I, sorry, just to round this off, can I also add that actually the right test is the one that is high quality and gets done, right? And what we're also finding is that sometimes it's not a question of liquid or tissue.
Yeah.
It's a question of liquid and tissue.
And finding both.
Because guess what? No test is perfect. There is
Yeah.
no test out there that can tell you I'm going to find everything 100% of the time, every time. Every test is going to miss something. The best-in-class tests are going to miss something. And what we are finding is through these cases, through the evolution in science, that there are so many of these rare abnormalities that exist, but there are so many therapies, talking about evolution of therapy, that are there already to target these abnormalities. So do both. Throw the kitchen sink at it and throw it quickly, because then you can avoid a year of not getting on the right therapy. You can avoid the trauma that causes, you can avoid the toxicity that the other therapy is causing, because the other therapy is not going to work. And so we need to make sure, to your point, to your question about right patient, right treatment, this is why it's important to think about shortening the diagnostic journey, throwing everything at it early so we get to that right treatment, because we're seeing clear outcome benefits from it time and time again.
but how do we know how the patient is responding to the therapy? How do we measure that? Because that is another, what I call part of the whole black hole syndrome.
Actually, I'll show you how. Okay, so this didn't just happen by chance. I'm surprised nobody asked what this is. This is something we call the tumor mutation map. So let's assume we found something the first time you were tested, and it was this light blue gene and that dark blue gene. And then you got treatment.
Let me pause you there. So when you get the report, it shows that bubble of the amount of DNA per ml of blood, and that's what she's trying to show. So if I found two different DNAs, one X and one Y, the smaller bubble is X, the bigger is Y, and that together makes your burden of cancer per ml of blood at that point on Monday morning when the sample was taken.
So at that time, the abnormalities that we're talking about and the amount of those abnormalities, maybe to make it simpler for understanding, is this light blue and this dark blue. And then a treatment was started. And when we used to talk about our test 4 years ago, we used to say, hey, the test is only at diagnosis or when the cancer progresses. What did we learn? Our doctors were actually using the test to see how the patient were responding to treatment. Because what would happen when there was a right treatment?
It's the bubble shrink.
You got the bubble shrinking. You see that in between?
Yeah, yeah.
Yeah.
So the whole bubble, the whole
You see
bubble.
this? The bubble shrunk.
So let's say you started the treatment at this point, and then you gave the treatment for this period. This is the timeline.
So
and you
forget
saw-
these words.
you
Just
saw
imagine
the
this is all
bubble
advanced cancer.
get smaller, and we saw that. We used to give the chemotherapy. Even chemotherapy, you see the bubble of mutation go down because the cancer burden has gone down, number of cells have gone down, and the DNA per ml has gone down.
Yep. And then on a CT scan, the doctor sees, you know what, the cancer's back. Now what? So we order the test again. What happens? Okay, light blue actually has shrunk. So you know, the therapy did its job on the light blue. It started shrinking. And I'm using these as hypothetical examples. You know, this is not an actual report.
No, but-
this is not,
but we have real reports
it
like that.
gives you the idea, right? So the light blue has shrunk. But what has happened? The dark blue actually did not respond. It's now the dominant gene. It's growing. And by the way, there is a darker blue that has emerged that was not there before. And why has that emerged? Because we said cancer is
Evolving.
evolving. And
Now,
so that's
if-
how you see the
And
response.
if I have a treatment to this, which you sometimes do, and you give the treatment to this, you'll see the whole thing shrink again.
And similarly, you do it again and you see, oh, now there's a red mutation. Yeah, you could do it the third time and see that that's come up.
I think
And
we
again,
need-
we're just using colors as examples, but I'm trying to explain the point here in as simple a manner as possible.
So I have a bunch of questions, but I'm going to try and limit them because I can grab Nitesh later on and really have a couple of hours discussion on this. Just two simple questions. One, how much of this is FDA approved? And two, how early can it detect?
Yeah.
Okay, so FDA approval for Guardant at this advanced stage is completely approved. So this is the first FDA approved liquid biopsy to be there in the market.
For comprehensive profiling.
Now, in terms of FDA approval, early stage cancer, stage 1, 2, 3 for colon cancer is near approval. I don't, Divya will have to correct me on that, but is near approval because the studies are positive. And earliest stage, which we call mass population cancer screening, is not there yet.
That was going to be my next
It is-
question.
it
How
is
far
not
away
there
are
yet.
we from an annual blood test that will tell you that you are, high likelihood?
So my
to get
guess
cancer?
is, and you can see that there are lots of articles, lots of companies trying to do that at the same time. My guess is we are less than 5 years away from actually saying.
Probably lesser.
And what will happen? Very interesting. There's a very big study of something called Grail. Multi-billion dollars went down the sink but they opened the door for the whole concept. So what they did was trying to say a cancer, and they failed. Not only did we not picking up adequately, but we also didn't know which a cancer. Then came in the others, including Guardant. What they said, let's just pick up breast cancer, just colon cancer, just pancreatic cancer, just lung cancer. And once you've done study for each of them, we'll make the whole bouquet together. So rather than a diffuse mosaic bunch, it's a bunch of roses. Each of them together will give you not only detection, now remember, this is not pre-cancer, this is earliest stage. So they can say, in the next 3 years, the more the data, the better, they will say, you are at a higher risk of prostate cancer. So screen your prostate every 3 months so that you pick up stage 1, you either burn it or take it out, and then you're done with it. No chemotherapy, no hormone therapy, no radiation therapy, and no more follow-up therapy.
Yeah,
So just taking that one step further, and this is a hypothetical, obviously, at this stage, because there's...
I'll say what your question is. Can we predict it before it happens? And the answer is actually yes. Now,
It should be, right?
This
I
is
mean, the physiology
so
of it is
now,
known.
This is going completely into the realm of developing science. This is developed science is being tested for data. This is tested for data now. So that's why saying it will come in less than 5 years. Developing science is, can we read the epigenetics, which is the changes the cancer DNA does to the organ of origin and the organ it's trying to go to. And if you can start reading that, and this requires a lot of AI and HI both. So as you start HI, human intelligence, as you start reading that, you will say, you are in fact at risk of prostate and breast cancer. You need to lose 20 kilos immediately. You need to go on a complete diet. And imagine the beauty of that. That then you test again and say, you know what, your epigenetics has changed again toward the good side. So this is right now fiction, but believe you me, Samir, in 2005 when I was studying my oncology in England, this was fiction. This was complete fiction. We used to sit and almost laugh at, what are you talking, blood and we will be detecting cancer? It was fiction. I think he's trying to make a point there.
Yes, I am. Good evening, doctor, and thank you for your valuable time. I'm asking this on behalf of someone, and it's, what's your opinion about a doctor called Dr. Berzinski in Houston? And he has been he's been doing a lot of studies, clinical studies, using anti-neoplastins and something called phenyl butyrate, if I've got it right.
Okay, what I'll do is after the meeting, I'll sit down with you and we'll go specifics of that. Okay? We'll go specifics.
I have a slightly personal question, if that's okay. Hi, good evening. Firstly, thank you so much for your time. This has been incredibly enlightening. My father passed away about 5 years ago from liver cancer, and he also had hepatitis. And so it had been like in his body for about 10, 12 years until which it was discovered, and then boom, 6 months later, he passed away. I say this to just give some context for my question, which is, of course, since the time he's passed, considering how quickly his demise came about, my mother, and to a certain degree even me, there is this paranoia, right, of, okay, who's next? And are we next, right? And so keeping everything that we've talked about that is in the pipeline or in research, if we look at today, as of today, 4th May 2013, right? How would you, and I won't quote you on this, but how would you as experts advise somebody to find a balance between, that paranoia of constantly wondering, is it going to be this kind of cancer? Should I just get myself tested for all kinds of cancer? What's it going to be? Okay. Or versus finding some kind of peace of mind? So the two
things you need to do immediately, other than completely stop alcohol, because you are at higher risk of these cancers. And it's not only liver cancer, they're associated with 3 other cancers of that area called hepatobiliary pancreatic cancers. So stop alcohol immediately, good food, good exercise, everything we spoke about. But you also need to see a genetic counselor. And you need to test your DNA for seeing if you are predisposed to developing cancer, right? My father has cancer, and we tested his DNA for a mutation which thankfully does not put me and my sister at risk of developing cancers. But I similarly know such people who are at risk. Now, the minute you develop that, there is in fact an algorithm to say at what age, to what age, and what testing you should or could do to detect that. The simplest example is Angelina Jolie, who found BRCA and actually managed to do a bilateral breast removal, sparing a nipple and skin of the breast, for the simple reason because her algorithm said she had an 84% chance of developing breast cancer in life. So that's something now. We have now genetic counsel available, including Dr. Dhar at Fortis with us. You can go through the counseling, go through the kind of testing you need to do and see if you're at risk. But other than that, no alcohol.
Thank you so much. Thank you.
I have to tell you this lovely...
Sorry, I just wanted to make one clarification, Samir, to your question, because I just want to set the stage for the approvals, right? So we are the first comprehensive blood-based biopsy to get an FDA approval. We also have a Japan PMDA approval for Guardant 360. For the rest of the products, in certain cancers, we filed for approvals, but of course the timelines are, we have to wait and watch. So I just wanted to put that caveat out there. And while screening is the part that always garners a lot of interest, and it has to, right? Because that's, as I said, the North Star, that's where we want to be. I think this is a discussion which is great, but it's probably a year to 2 years earlier than where technology will be to give not just comprehensive answers, but then clinicians will be able to know what to do with those answers. And a lot of those data, going back to what you said.
You have to be even more right there.
Yeah.
If a stage 4 cancer, you have to be right. In a person who's not a patient, you have to be even more right.
Yeah. Yeah. And as a clinician, I mean, patients are going to come back and say, well, what next? And so we have to be very sure that the data is mature enough and the data is developed enough and the clinical practice guidelines on that are thought through and bring it to market. And that's why as a company for screening colorectal cancer will be the first one that we bring to market. But then we're thinking through all of these aspects with doctors. And I think happy Saloni to have another session next year, maybe to talk about screening, because that will be something I think of interest for everyone out here.
So, I did genomic testing 10 years ago. There is a company called mapmygenome.com. So I was their first customer and stuff like that. And because I've been surrounded by cancer, both from my father and my mother's side, I did cancer marker tests almost every 6 months. I'm a huge one for testing. Okay, I've probably been tested 5,000 times for COVID. Okay, which is why I got it 3 times. Anyway, so I have to tell you this incident. I go to Dr. Rohatgi and I said, Doctor, this time we have to get all these markers done. He says, why? I said, no, because I'm surrounded by cancer. He says, yeah, maybe. He says, why don't you meet this lady before you do these things? So he put me onto this lady who's a geneticist. And she made me and my wife do one entire plan. And she made me remember my uncle, my cousin, everyone in my family, people who I haven't thought about ever in my life, okay, until that moment. She says, when did he get cancer? What age did he get cancer? And she came to a conclusion that possibly there is no chance that I can get it, though everything that Dr. Rohatgi today has told me tells me that
about behavior.
I must get it.
I'm surprised there's no guidance for him.
Yeah, there's no guidance. Yeah, but yeah, I think...
There is a guidance, he doesn't obey that.
No, but sorry, you had a question. Can I
have the mic. Yeah, so we were talking about technology in medicine. And while it's fantastic to see what Nitesh you mentioned around, between 2005 and where we are, but for a common person like us, we still feel that cancer technology has not made much headway. I mean, we are still struggling significantly, and the kind of therapies that are there. So I have a couple of questions around it. One, do you think the reason for that is it because of say the stranglehold of pharma companies? Is it around FDA issues? The real the time to market is very difficult. Like you mentioned, you are in clinical trial and you hope to get somewhere in a few years. And another part of that question you mentioned around data and how we can use AI, but data is limited. How can companies like yours use Indian data? In America, I'm sure you won't get the data that Indian market can give you. How are you guys using data efficiently so that we can really get this time to market much better than what we are? I mean, we don't need to wait for another 10 years to get to the therapy.
Yeah.
So.
I'll answer first question, and you take up data because I've been telling them to do exactly this. Okay, but essentially, you're right. I think when we talk about handling cancer as a whole, we are that small right now. But that small has seen the biggest improvement in the last 10 years. So we've just started to learn really how to manage cancer better. For 40 years, we were operating, chemo, operating chemo radiation. It's only last 10 years from when I qualified to become, because I qualified to become medical oncologist maybe, but from when I qualified to become a medical oncologist to when I'm now practicing, every 6 months, Abhishek. And you've seen me do that. Every 6 months, I change my stance because something new happens. That's a very, very, very rapid pace. So we are learning. We are way better than we were. But I think we will be treating this completely differently in 10. And I think in 20 years' time, we may be just diagnosing a lot more at a very early stage. I think AI is the key. I think data is the key. And I think if we get input of data wrong, we'll actually do a lot more disservice than we can imagine. So we have to be careful about AI in hands of doctors who at best, and you know some of them very closely, are very poor at talking about data.
Dr. Rohatgi, I have a question. You mentioned the 5 most important things: alcohol, smoking, nutrition, fitness, etc., etc., etc. Don't we see actually today, in today's society, especially in today's urban society, an increased awareness of fitness, nutrition, diet, etc.? Second, another question with regards to diagnostics. When we talked about 1.3 million people being diagnosed every year with cancer over here, my sense over here is that, and correct me if I'm wrong, is that we are actually getting better at diagnostics thanks to something like this. Her poor father apparently had cancer 14 years ago and was detected with it a year and a half ago. So that shift, now there's this fantastic book written by Dr. Siddharth Mukherjee, I think, The Emperor of Maladies, a biography of cancer, where he talks of cancer as always having existed. And also that if everybody's average age went up to 150 years, we would eventually, all of us, get it.
160 actually,
So if something like that, but the point is that as diagnostics get better, isn't it inevitable that we will see more number of cases, and we shouldn't be too alarmist about it?
Yeah, so that's exactly what Swapan was saying about hope versus cynicism. Divya was saying, I'm hopeful that we'll be able to conquer cancer. I said yes, but it comes with cynicism, we'll be diagnosing a lot more. But if you're diagnosing a lot more at the earliest stage, or as we're saying, that's what Samir and I are talking about, epigenetics and diagnosing even before that, and say, let's change our lifestyle, then I think we're actually treating it very differently. It's hypothetical at the moment. It is very utopian at the moment, but I can see how that will become reality one day. I think you wanted to answer Abhishek's data question.
Yeah. And also maybe just to add to this one before I get to that question, I think my hope with conquering cancer is a big vision, but my hope is, and what we were discussing earlier, and I was saying that certainly in our lifetime, we will not think cancer is a death sentence the moment someone says you had cancer. That fear that word instills in all of us, I am hopeful will come down because we will have better therapy, better diagnostics, we'll have better guidelines and education and regulatory approvals and market access and everything else that needs to happen to improve adoption, such that we will think of cancer the way we think of diabetes. That yes, ek din to marna hai, but aaj nahi marenge. Like it's a chronic disease. We'll manage it. We'll work with our doctors to manage it. And that's my hope in whatever cynicism that exists around cancer. To your question about AI, and to what Dr. Nitesh said, so we have a machine learning algorithm. What's our IP? Our IP is you can sequence, but then what do you do after you get that data from the sequencing? And that's where our IP lies. And the IP is on a machine learning algorithm where the more you train that algorithm, the better the output is, right? And so far for advanced stage cancer, we've put 250,000 patients in a real world, in a clinic, Dr. Nitesh's clinic, Dr. Agarwal's clinic, Dr. whosoever around the world, about 12,000 oncologists using us in clinical practice. That helps. And that is in addition to everything that goes into the system for the hundreds of clinical trials that have happened. So that training of the AI algorithm helps. Now, how do you start adding in better sensitivity when you start getting to the earlier stages of cancer? That is not just about the abnormality in DNA that we were talking about earlier. Dr. Nitesh has used a word called epigenetics a few times. So what is that? It's your behavior and environment that's causing changes in the way your body reads that DNA. Not necessarily changes in your DNA, because that can't be reversed. Epigenetics a number of times can be reversed, but the way your body reads that DNA. Now that's where it gets really interesting, because this is a whole new area. I mean, look at the amount of cells we have in our body, look at the different epigenetic signatures that they have, combining them to make sure that we're picking the right signatures for the right cancer for stage 1 and 3, and then doing it all over again to see what's the signature for screening, is where the technological advancement really becomes cutting edge, which is where the need for the right data training the algorithm becomes really important, and hence the need to have large data sets. So it's not important to have now a 200, 300, 400, 500, 1,000 patient data set. Our first screening trial has 20,000 patients data set done over 200 centers. And the data will be, which is embargoed, will be presented pretty soon in the US, and we'll be able to share it soon. So this is where the game changes completely in terms of both the number of samples you have to put through and the kind of data you need to generate.
Yeah, but Abhishek, you're right. They won't get it right. Okay, they will not get it right till they do it in India. Okay, they will not. So only India can solve health and AI for the world. I have a paper in the Policy Institute, King's. It's quoted there. Only India. Now we are the biggest population as well, but China is closed source. India is open source. We are the biggest telephone users in the world. You cannot collect data by healthcare providers because we are useless at it. Any healthcare provider which wants to do a very good job will keep data to themselves. So it will be all Max, all Fortis, all Apollo. It's a waste of time. The only way to collect data is collect the patient to the telephone, to the data, to Guardant 360 or tests like that, and then you'll see the beauty of it. And they can't do it. They're an American company. So only, I beg to differ, I'm sorry. But the only people who can solve this is people in the room and outside with an entrepreneurial mindset who will force, and there are ways to do that, who will force the patient to put in the data, own the data and put in the data. And I am guessing, and I've said this to Chief Secretary, if you give only 20,000 rupees tax rebate to an Indian patient, they will put the data in. Only 20,000 rupees tax rebate, they'll put the data in. And if India puts its entire cancer data of 1.3 million people, we'll solve this within 5 years.
But you're talking about clinical annotation data.
I'm saying if a patient gets 20,000 rupees rebate on their tax, they will put every bit of information that I ask, which is a 1 hour thing which I cannot put in my clinic.
Yeah.
That was my point, that in America, for you to get that data, it will take 10 years. Then you go to FDA for another 5 years. In India, if the companies get together, there will be a way to get this data, like you mentioned. And then you can accelerate. It's all about data. You need to try those trials.
Can't they?
There are companies like DeepMind who've done that protein folding after 65
Yeah.
years, which we couldn't solve. So I'm sure with data, companies like yours can solve a lot.
You see, but this it is a bit of a fallacy that big pharma is they're not avoiding anything. They're the first one to pick up something like a mustard seed and make chemotherapy. They're not doing anything. But it's just that it gets very difficult in a country where you have to prove beyond doubt, and that's a whole different discussion about the insurance and that. You have to prove beyond doubt, otherwise the evaluation and everything else goes out. So again, I say, only India can solve health and AI in the world, nobody else.
I think you just need to give Nandan Nilekani the project. And he'll do a damn good job. No, I'll just round it off now a bit. So how do we crack this entire affordability thing? How do we get banks, insurance companies into this entire diagnostic thing? Because they need to get into this, because this requires some kind of money which most of us don't have. The largest part of this country does not have. So how do we crack that? I know we talked about it, but why don't you share your views, Doc, and then you, Divya.
Okay. I I think by doing things like we're doing right now, that's how we crack it. We crack it organically. We crack it by having conversations. It is not that our test has not been covered. We've actually been really lucky. We have had CGHS cover our test a few times. We've had, and I'm 100% sure I'm going to get the acronyms wrong, but we've had the railway and army hospitals cover our test a few times. But it's all been through a process with a lot of support from the doctors, a lot of education in terms of content from us, letters of medical necessity being provided by the doctors, and finally them actually seeing proof of concept after many patients that, yeah, this is actually helping guide treatment. That is one way to do it. The other way to do it is to actually sit and have conversations with insurance companies. And just like I feel bad for doctors, I feel bad for people developing market access models, because their thinking of genetics has always been, it's hereditary, it's telling me about risk, I need to see what this does to my premiums, right? Like that's sort of been the mindset. Here we're saying something very different, especially when it comes to advanced cancer patients. We're saying, and I think you said this earlier, we're saying, you know what, the cost of the test in relation to the cost you're going to spend on the therapy is actually a fraction. Get the test right so that you can actually avoid the wrong therapy being given and avoid covering the wrong therapy. And I think there are, I'm actually very heartened because conversations that I couldn't have with many doctors 5 years ago are conversations I'm having today. Similarly, conversations I couldn't have with many insurance companies 2 years ago. We're finding traction with insurance companies and starting to have these conversations. And I think it will get better. It will take time because unfortunately, regulations and access always lag behind technology. Any one of you who've been in the tech field have seen this, and we're no different.
Okay, to my mind, there'll be three-step process here. Everybody will push, and insurance companies will cover, and things will happen. Second, volumes will build, so the cost will come down as economy of scales go up. But third and most interestingly, as we become the center of the piece where we start diagnosing cancer, because between the government and the CSR and everything else, there is a push to diagnose cancer early, will actually change the whole game.
I've done very few decent things in my advertising career, but one of the things that I really am happy and proud of is the fact that, we created the concept of the preventive health package, okay, for Max, and then, it went on. And the important lesson that I learned there was that the critical part is to demystify the price. So let's say a blood test that costs 1 lakh of rupees. If you demystify it to me and say, that's almost less than the cost of a return ticket from Delhi to Bombay once a month, okay? And I think if we demystify that price, it just makes a big difference to consumers, because 1 lakh is one thing and 8,000 rupees per month is another. And it's just a perspective that you need to think. But I totally agree with you. I think insurance companies and even banks, like Suchitra and I have a common dentist who's obviously stayed away from this conversation. But I told him, I said, ye kaisi badtameezi hai that you make a 40,000% profit on implants. I mean, why would you do that as a human being? So he said, but that's the way it's done. So I think, advocacy, evangelization, education, empowerment, communication, I think will make a substantial difference to changing the world with these form of diagnostic tests, and we owe it to each other. And I think if we can help each other and disseminate this information, that'd be wonderful.
100%. If each one of you over here, put it on your WhatsApp groups that, hey, anyone with cancer, make sure you're having a conversation about diagnostics and you're having this conversation early. That's already something that's not being done before. If you know patient advocacy groups, and I think somehow everything happens on WhatsApp in India, so whatever WhatsApp groups that are leading patient advocacy, go tell them, talk to them. It's a conversation, and empowering the conversation and having the conversation is important. It doesn't matter whose test you get done, as long as you're getting a good quality test done on time to get to the right treatment. I think that's what's important.
I'll go one step even simpler, okay? Everybody in this room actually is cancer sensitive, so is sitting here. But there is, my guess is still about 1:100 population which is not cancer sensitive.
What do you mean by cancer sensitive?
They're not thinking about cancer.
They're not thinking
You
about
put
it, yeah.
you put cancer on the newspaper, they'll flip that page. Okay, so they're not cancer sensitive. They are basically not recognizing that our population now is the urban population in India sitting as the American population risk of cancer almost. They're not recognizing that. So the biggest and the single most thing that everybody in this room and everybody should do is go out there in your groups, in your conversations, start speaking that at least if you've got a symptom which is increasing and your physician has checked you out, given a medicine, is still getting worse, please go and ask him, could this be cancer? Simple question. Could it be cancer? Believe you me, a lot of physicians don't think the first time round. But when you go back and say, could it be cancer, they will end up doing a scan and you will at least start detecting more cancer in earlier stage than we are today. This is here and now. It is a fact that the biggest gap is in people who have early stage cancer ignoring that.
Any last questions from any of you?
Okay,
Of course,
one,
Suchitra.
I think last one, because we've yeah. It'll be,
Thank you. Thank you. Thank you for your time, and thank you, Swapan. It's funny. Interestingly, one of my very dear friends from school is your recent patient. Found out she had cancer just because she saw a WhatsApp forward that said it was something about cancer and get tested. And on the basis of that WhatsApp forward, she went and randomly got tested just because all her appointments got cancelled the next day. And she found out it was very, very, very early stage. She's just had surgery and she won't need chemotherapy. And while we're talking about precision testing, it just boils down to luck, how you find out. So for people who are really, once they get diagnosed, it's extreme precision testing and suddenly everybody in the family is an expert. But it's how you find out, which is so much in the dark ages, which you said will get better over a year or two. But, so I was there at one of the fairs where Max was giving out pamphlets and hospitals are going above and beyond to say, we are giving you a free mammogram. Here, take 5 free coupons. You'll save $5,000 per something. I still didn't use it. I couldn't give it to somebody else because I just thought they'd take it badly. This is how bad it is. Yeah. And I also feel that, and I'll come to my question right after this, I also feel that I don't know why it is only with this disease that you have, and I've lost people in the family also. It's stage 1, stage 2, stage 3, stage 4. People die more with the flu than other things, and I'm not equating the two by any means, but I'm saying the moment you hear stage 3, it's not maybe the cancer or the heart attack that will kill you. Because it's just like it feels like a death sentence. And people who I've known have isolated themselves because it's just doom and gloom. Yeah. And maybe that needs to change in the, and like you said, it's human intelligence and everything is correlated clinically. Yeah. Because it's how you feel and it's just your world changes and comes crashing down. So is there something to not say stage 3 or stage 4? You have it or you don't have it. There's no such thing as...
Okay, I'll quickly address 2 things.
Yes.
A, I do think that as friends, as groups, you need to set up your yearly appointments for mammograms.
I agree.
If you're at that age. I think it's obligatory, and I think unless you do that as this is our day of the year, 5 of us do it together.
100%.
And that's the only real way to do this. Your friend got it by chance. She was lucky, but believe you me, I see more advanced cancer of patients who say, I could have detected 6 months ago, I did feel a lump and I did feel something, and I had bleeding in my urine and I ignored it. So I see so much of that, and I start thinking, what if then?
Right.
Question number 2, and this was more pertaining to stage 1, 2, 3, and 4. it was never meant to be public knowledge. It was always a technique for us to collect data and decide how do doctors treat stage 1, stage 2, stage 3, stage 4. Right? It was not meant. The public knowledge was, your cancer is early, you need only surgery. Your cancer is a bit longer, you need chemo and surgery. And your cancer is advanced, we can't cure you, but we can treat you. That was public knowledge. My favorite country in the world, somewhere, decided to start putting it out in the open forum. I think everybody's guessed which that is. And started saying this is stage 1, stage 2, stage 3, stage 4. And patients said, what does stage mean?
Yeah.
Right? But I still delayed till somebody asked me what stage is. I say, you've got very early cancer. Surgery alone will do the trick.
Okay.
You don't understand stage 1. For me, stage 1 lung cancer and pancreatic cancer are entirely different things.
Yeah.
Yes. Okay. And
Like stage 1 cancer, it's an early cancer. What do you mention stage 4 cancer then?
So that's what I'm saying, that it is not that simple. It's not 4 stages. A stage 4 lung cancer with certain mutation is far better than a stage 1 without. So I'm just saying it's not that simple. Your question is not stage anyway. You come to the doctor asking, is there a treatment, is there a cure? That's your question. And what will it take for that cure or that treatment? And again, the problem is we were not trained in communication skills in medical college.
Yeah. Well, it doesn't seem to apply to you, but okay.
so Dr.
No, I was not trained in medical college. I was trained afterwards. But we were not trained in communication skills in medical college.
So Dr. my question.
Can I
Sorry.
just make one
Yes.
comment on what you said? I think part of it is also you're not alone, right? We're following these statistics across countries that have made the entire health screening process completely free. So mammograms, colonoscopies, guidelines exist. Which age do you go? Why do you go? Everything exists. Singapore is not free, but you have very low cost. You have Korea where it's nearly free. Like many countries are trying, right? Compliance rates are really bad. Why? Because there's a fear of I'm going to have pain. There's not enough education about why I should do this. The pamphlets that come to me with education have these 2 plates and a breast being squeezed between them. And looking at that pamphlet is certainly not encouraging me to go and get that test done. And the same thing about a test like colonoscopy. My parents are over 60. For the life of me, I can't convince them to go and do a colonoscopy because they don't want to go through it. No one wants to go through a stool test because it's literally shitty. Yeah. So there's so much phobia and convenience factors and all of these things attached to it. And that's a great lesson, and I've had similar lessons in my life where I feel the best test is the one you do it, right? Just go do it. Whatever exists today, follow it. Don't wait for something better to come up. Just do what exists today, because...
Time will change this. We are innovating into much easier tests.
Yeah.
Right. So my one question is, Doctor, my understanding is that everybody has precancerous cells. Does everybody have precancerous cells, and does that show up in the regular annual checkups as markers for GPs?
We'll address that first. So if everybody lives to 160, cancer incidence is 100%. That's a model from Boston, which is what was quoted in that book. And all that means is cancer is a part of evolution. Okay. The same thing that made us human beings is also the same mechanism cancer is using, right?
Okay.
As we degenerate, as our cells change, they can't cope with that and things have to go wrong.
Right.
It is a mechanism given by evolution because mortality is important, right? But when cancer cells develop, body also kills them at the same time. So what we call...
Best thing I've heard all evening.
That's why majority of us have evolved into, being 45 or 55 years. And I have a theory whether we should be 55 or 85, that's a different day. But the point is that cancer is being killed at the same time. It is the imbalance of the correcting mechanism that goes wrong for the cancer to go up. And no matter how we look at it, the biggest reasons for that imbalance of the correcting mechanism is alcohol, smoking, sedentary lifestyle, obesity, processed red meat, viruses.
Okay, great. So does autophagy and therefore killing and renewal of all the body cells over a fast help?
Continuously. Oh, very interesting question. We'll talk about this after the meeting. One line answer, I do feel it does.
Sorry, you don't
I do feel it does.
You do feel
I do feel it does. Intermittent fasting at certain level, I do think it does.
Thanks very much for being here. Very important for us. And yeah, if you can just spread this across even sets of 5 friends of yours, I think we're good to go.
Yeah, no,
And the
thank
world
you,
will become
Swapan
a
and
better place.
Saloni.
No, pleasure. Always.
Thank you, all three of you, and very valuable time that you've shared with us. I think the fact that we're all still murmuring and us wanting to talk to you more, that's a good sign, and please do mingle after this. But again, you know, we would never have been able to access this kind of conversation anywhere else. So thank you for making it happen, Swapan. Thank you for coming, Divya. Thank you, Doctor. Really, very useful. Thank you, everybody. And good night.